Would you like to know more about Pentax Medical's commitment to infection prevention? Read more about our hygiene commitment on our website.
With us here in the studio, so I'd like to say, Bruno, it's all yours. Take it away.
Thank you very much, and thanks for being part of this interesting symposium. And indeed, I'm going to talk to you about the burden of an outbreak due to contaminated endoscopes, and that's mainly because I was part of one of these outbreaks, and I have some inside knowledge. These are my disclosures, just to start with my presentation, things that I do for companies and involvement in societies and governmental institutions. And to start off with, the question is, of course, as we do endoscopy already for many decades, is this whole thing with regard to endoscope contamination and patient infections a new issue? And it's not. It's as old as endoscopy has been around, and if you look in the literature, you will find very old reports already of contaminations of endoscopes. I think in the last few years, we have been kind of ignorant to the problem. The complications of contamination and reusable endoscopes. Until a few years ago, when some of us got kind of infected with these scopes, we had contaminations, and patients become infected with some bacteria. The reason also why we now have more attention is that the number of endoscopies over the world have increased with such a huge number. Also, we're doing endoscopies in sicker patients, elderly patients, patients that are immunocompromised, and simply the risk of contamination and attracting an infection is higher. If we look in the literature and we look at reports of incidence of infections after ESP, it's somewhere between 2 and 4%. In my view, this is grossly underestimated, and to get a grip on these numbers, it's important to be knowledgeable about a few concepts. First of all, if we have an infection after endoscopy, we can talk about endogenous infection. And that's an infection that we cannot prevent because it's simply the transport of bacteria that are already inside the gut lumen of the patient into the bloodstream. This is an inherent complication factor of endoscopy. But we also have exogenous infections. And that's when we truly bring in a bacteria from a patient that was scoped before into the next patient, and that's something that is preventable. And in fact, we should prevent that from happening in patients. It's always very important to have the knowledge about the concept of what we call multi-drug resistant organisms. So organisms that are resistant to certain bacteria, and they become kind of apparent because they tend to occur in clusters, and that's the reason why we as physicians, but also our microbiologists, are kind of attracted towards a possible outbreak. But you also have pan-sensitive microorganisms, and that's an organism that responds very quickly to antibiotics. So even if you have a patient where you bring a bacteria from a previous patient to the next patient, that patient will get fever, but you just give antibiotics, the patient recovers within 24 hours, and you probably won't even assume that it might have been a device cross-contaminated type of infection. These contaminations of scopes in the beginning have been kind of brought into kind of view with regard to breaches in reprocessing, but it's very important to realize that there have also been outbreaks very well documented where there were no breaches in the reprocessing process. As already was alluded to, all these outbreaks have been linked to, in particular, complex endoscopes, scopes with a complex design that are relatively difficult to clean. We in Rotterdam, where I'm heading the department, were confronted with an outbreak dated back to April 2012, where all of a sudden there were 30 patients with a VIM2 positive Pseudomonas aeruginosa identified, and it was kind of apparent that 22 of them had undergone an ERCP at that time with a specific endoscope that we used, the TGF Q180V. Those 30 were an enormous significant increase as compared to the normal kind of numbers of outbreak in hospital, about 2 to 3 per month. And then, of course, we started all kinds of investigations, epidemiological, genetic and technical investigations to find out what was the culprit and the cause of this infectious outbreak. This is an important slide to show you because we dismantled the scopes that we thought were involved. And although these scopes are only a few months old and had not been used in that many patients, you can already see that there is quite some wear and tear on these scopes. For example, at the area of the lens, you can already see some corrosion having occurred behind the lens and the glass plate. You can also see that there are some cracks and breaches in the plastics surrounding these areas. Also importantly, as you can see here in the O-ring, which is supposed to kind of seal off the outside world from the inside world, you see cracks. And if you look very closely under the electron microscope, you can see that the surface is incredibly rough. And indeed, we found fluid behind the O-ring. We did these epidemiological investigations, and in particular, and that's important, molecular typing of these duodenoscopes. And we could show that the infection that we found in the scope was exactly linked to the infections we found in the patient. So that was a causal relationship. We found, in particular, materials under the forceps elevator, and that was that Pseudomonas aeruginosa that we then isolated. There was some kind of biological materials where this kind of clotted and adhered behind the forceps elevator. The outbreak that we had in our institution immediately ended when we took both of these scopes out of service, and that was in March 2012. And I showed you what we did in the technical university. We completely dismantled the scope, and in particular, the technical people found the things that they found with the O-ring, the leakage, very concerning and an important area of potential improvement of scopes. Now, should this all be a concern? Well, I think obviously, because worldwide, multiple patients have become very seriously ill, and also some have died. If you now look in the literature, there are more than 40 infectious outbreaks reported. 35 deaths have been reported, and I'm sure, as was already alluded to, this is only the tip of the iceberg, because I believe that many colleagues around the world do not recognize infections in patients as related to endoscopes, in particular when sensitive bacteria are involved. And even if colleagues have had experience with infectious outbreaks, they didn't publish it in the literature. So we don't know about it because there's no registration of infectious outbreaks. So there's reporting bias in the literature. It's also important because not only there's patient burden, but endoscope-associated infections prolong hospital admission and, of course, are related to cost, because in hospital admission and giving patients antibiotics and even ICU admittance, a lot of costs are involved. In the Netherlands, we did a cross-sectional examination study where we cultured all complex scopes, so duodenoscopes, ERCP scopes, EUS scopes. And of all the scopes hanging in the dry cabinet ready for use in patients, 13% was positive for an oral or GI bacteria, independent of scope type or brand. And the fact that we found this oral or GI bacteria, that means that must have been a bacteria from a previous patient. So this is surely something that you want to avoid. Another important concern, I think, in this whole topic, which is not often addressed, is the fact that endoscope-associated infections are treated with broad-spectrum antibiotics, and they can cause multi-drug resistance. So sometimes we have a multi-drug resistant organism being involved in an outbreak, but if we don't, we give antibiotics, and because we give them, we might induce multi-drug resistance. And that's incredibly important, and the World Health Organization recognizes this, and as you can see, they have some statements. Antimicrobial resistance threatens the effective prevention and treatment of an ever-increasing range of infections caused by bacteria, parasites, viruses, and fungi. And a second statement, antimicrobial resistance is an increasingly serious threat to the global public health that requires action across all government sectors and society. Now, what is the chance that an individual patient gets infected? That's a question that's often been asked to me. And that's a difficult question to answer because it's a highly complex chance calculation with some cumulative probabilities, and it depends on many factors. First of all, the prevalence rate of bacteria, in particular MDROs, in patients undergoing endoscopy. And there is a huge variation across the world in different countries with regard to the MDRO prevalence, which can range somewhere between a few percent up to 60–70%. The risk probability that the endoscopy is performed with a scope that is contaminated by virulent bacteria, and I will show you a slide later on to kind of illustrate this with a typical MDRO. Marion alluded to this very, very important training and compliance of personnel to the instructions of cleaning scopes. A systematic monitoring of contamination. I think that you should at least every month culture scopes to be aware of a potential contamination. It is not a for sure type of system that you introduce, but at least you get some feel of whether scopes are contaminated. Very important patient factors. The sicker the patient, the more immunologically compromised the patient is, the more likely the patient will be infected. And of course the type and the duration of the procedure. The more you breach mucosal barriers, the longer you are endoscoping, the higher the likelihood of bacterial translocation. Now, in view of this, we did a recent investigation with regard to an outbreak in the Utrecht Academic Center, where there was a multi-drug resistant outbreak with a Klebsiella pneumoniae related to two scopes. There were 102 patients that are undergoing ERCP scope with these two affected scopes. They were all invited for screening, and we did cultures of 81 patients who were available, and we had 27 patients with this multi-resistant Klebsiella pneumoniae. And then you can do a kind of a simple calculation with 10 patients really having an active infection. So the remaining patients, 17, were carriers of the MDRO and might then cross-contaminate devices or next patients, for example. But these two endoscopes had attack rates, so that means if the scope is contaminated, the chance that if you then get scope with that scope, that you will get an infection is 35% and 29%. So roughly 1 out of 3 patients that were scoped with the contaminated scope got an infection, or at least got contaminated, which I think is a very serious concern. So to get to the end of my talk, I think that infections transmitted by complex endoscope are very real, and we should be concerned about this. Their incidence is underestimated, and what we know is probably the tip of the iceberg. They cause substantial burden for patients, obviously, but also for the healthcare system in terms of labor, time investment and costs. The recognition of these infections or these contaminations requires awareness. You have to be knowledgeable about the potential of contamination and how this works. You have to be vigilant with regard to trying to show that there's a possible contamination. And lastly, also very important, prevention of scope-related infections requires dedicated teamwork, constant monitoring, close contact with your microbiologist, and importantly, the people in the endoscope department should regularly have contact with the people cleaning their scopes, because they are the ones that make sure that the scope that you use in the endoscopy room is safe for your patient. Thank you very much.
Thank you, Professor Bruno. Those are quite some significant, serious numbers that you mentioned here. 1 out of 3, if the scope is contaminated, that a patient might have some very serious implications. Is it at all possible to kind of talk a little bit about the true costs, maybe even from a monetary point of view also, of the outbreak that you had in your hospital? And what would be your specific recommendation to prevent something like this?
It's incredibly difficult to put a true number, of course, but I can tell you, if this happens, the investigations you have to put up, trying to trace back infections and potential contamination patients, it's a lot of work, labor work. The cultures cost a lot of money. You saw we took out of a surface these 2 scopes. We completely dismantled them. So we took the responsibility to start up a whole investigation trying to get to the bottom of the reason of the contamination infections. That cost a lot of money. It's not possible for me to put a number on this, but it is very much something you want to avoid. And with regard to trying to prevent this, what is incredibly important is, in my view, we will, with the reusable devices, we will not reach a 0 level of contamination. It's just impossible. We don't have much time to go into this, but the level of the margin of safety we have with the current reprocessing techniques is just not good enough. So there's always a chance of contamination, but in particular the strict adherence to these instructions of the manufacturer, which is not easy, because Marion already told rightfully, there are 130 steps involved to clean a scope, and every scope has a different instruction set. So imagine for these people in the hygiene rooms to clean the scopes, a mistake is easily made. So we have to give them the proper position within the endoscopy team, that they are recognized for their work and that they also understand that what they do is important for the safety of the patient. And strict adherence, and in particular what many people forget, the manual pre-cleaning. The manual pre-cleaning step is the most important step of the scope cleaning process. If the manual pre-cleaning is not done sufficiently enough, the whole high-level disinfection will fail. I think those are the most important topics for.
Okay.